So, good afternoon. First of all, I would like to say that I feel honored by this invitation, and it's great to participate in this webinar group about aligners. And at the same time, I want to congratulate this amazing organization. So, the topic for today is occlusion and craniomandibular system in aligners. I'm Heloísa Alves. I live in Portugal, a small country in Iberian Peninsula, and I live in the south of Portugal, in Alentejo. Alentejo is widely recognized by the Golden Plains, the good meat, amazing nature, cultural heritage, seafood, tasty cuisine, and a good quality of life. We are part of everything we have found, including in science. And behind biomechanics, I would like to say some concepts, my philosophy of treatment, and I want to share with you behind biomechanics and talk about biology. The most positive influences that I have in my academic journey, my 20 years of orthodontic journey, was Professor Rudolf Slavisek and Professor Sado Sato, two teachers, two professors that I have in my master degree in dental science with the focus in orthodontics. It was at that time in the University of Krems in Austria, and then I continue with these two big minds that influence and completely change my point of view of orthodontic and occlusion. They inspire me and create new concepts. Then I continue with the investigation during my PhD with Professor Sado Sato in Kanagawa Dental University in Japan. And three important concepts show very importance in orthodontic and occlusion treatment. And is the first, posterior discrepancy, occlusal plane, and vertical component. I continue with the investigation in craniomandibular system in University of Anthropology and Coimbra in Portugal. And I realized that orthodontic treatment is very behind occlusion. We must study and understand the whole 3D craniomandibular system. So for understand occlusion, we must understand the evolution of human head. We have different phenotypes in Homo sapiens sapiens today. We have different craniofacial systems and skeletal patterns. Understand the evolution of the design flow of the human body does not just satisfy curiosity. It's an important tool to prevent and treat disease. A quick change in the autonomy of the skull base results in a marked development in all craniofacial structures. All these morphological changes occur in a very short period of time. So the cranial base changed over a million years, and we start from Pongids has a flat occlusal cranial base, and the more we go closer to Homo sapiens sapiens of today, the more it flexes. So can we consider the craniomandibular system and the occlusion or maral occlusion as a genetic factor or epigenetic factor? Pongids and humans are different, and you have the anatomical difference, but the most important difference is in grow. In Pongids, we have a grow in anterior and inferior position, but in humans, we have a vertical component. They are very similar in a newborn crania, but then when grow, they have completely different directions of growth. So this component, vertical component, belongs to humans, to Homo sapiens sapiens of today. And another difference between these two is the occlusal plane. In primates, we have a flat occlusal plane, but in humans, we have a steep occlusal plane, more inclined occlusal plane. Another difference and another problem to humans is the arch. In primates, we have a big arch and we don't have a stop in anterior teeth. So mandible can go in a protrusive way without block. But in humans, we have a parabolic arch. So the movement is very strict and we cannot go protrusive. So we make retrusive movements of the mandible. And this creates a problem to our TMJ. Like Professor Slavisek and Professor Sadel, they call the risky joint. Why? Because we lost the postglenoid bone that protects TMJ in primates. We have a vertical component of growth, an unstable craniofacial system because of the B posture, and we have a closed arch. So we have a danger and risky joint. And we cannot treat orthodontic and occlusion and without think what's happening with our joints. So human creates a new mechanism, a craniomandibular system with ligaments and create a capsula and support to this TMJ, but we don't have the lock-in canine, we don't have the bone, postglenoid bone, and we don't have open heart. So careful with orthodontic and occlusal treatment. If we continue in research, and in this 3D skull project I made between the university in Portugal and Japan, we achieve data acquiring from Coimbra and Lisbon. From Lisbon, we have the 20th century database, and from Coimbra, we have from 17th century to 20th century. In total, we analyzed 2,455 skulls in 3D with cone beam Galileos with CBT scan. And all the skulls are studied in a very standard format. We go to scanning procedures with CBT scan, and then we export to a Maxillium software, and we make our cephalometry. And the results we obtained from this database and this investigation was amazing, because we have class 2 in all the centuries, from 18th century to 21st century. Now we have 56% of class 2 in Portuguese population. And if we compare this study with the European study and Japanese study, we see very similar the result from Portugal with the European, with the 52 class 2, more in European study, but in Japanese study we have more prevalence of class 1, 53, and not class 3. So we don't achieve the class 2. We born with class 2, and we can fail to reach the class 1, or we can over-adapt to class 3. This is a new concept. So anterior-posterior is not the cause, is the outcome, and the vertical component of growth, characteristic from human species during evolution, is the cause. This study is already published in this article. If you want, you can send me an email and then I can send you to read. And another result, amazing result from this research was that we have, even today, a very 3D changes in craniomandibular system, not only in past in evolution. And we achieve that the anterior cranial base is decreasing the century by century. So we have a variable of SN that decrease from the 18th century to the 21st century. So evolutionary adaptation is not only possible today, but is 100 times faster than in past. This is already published too, and I can send you the article if you want in the end. So if we continue to observe these specimens of this research by eyes, we can see that this anterior cranial base is decreasing, vertical component is increasing, and if we focus in the occlusion, this is amazing, the difference that we can see here. From 17th century to 20th century, in the beginning, we have more abraded teeth, not only in the surface, occlusal surface, but in interproximal too. And after the 19th century, we don't have so abraded teeth, and we have not so much space and more crowding, more posterior discrepancy. And why this is happening? Because in Portugal, in 19th century, there is the Industrial Revolution. So diet, it was completely different from 19th century. So there is a strong evidence that the dentition evolves by functional adaptation to different lifestyles and diet. The development of facial and mastigatory structures depends on the demand of mastigatory function. And if we go more closer to the upper arch, we can see we have only 4 centuries, and we can analyze that the upper arch is very narrow now than before. It's closing the arch, and the mandible getting more smaller than before. So we have here another problem, not only a closed arch, vertical component of growth, instable TMJ, but we have here another problem for humans today, the posterior discrepancy. And what is posterior discrepancy? If we focus in this image, everyone in orthodontics know about anterior discrepancy. We know that is the relationship between the sum of the teeth and the arch. But what is posterior? Posterior is between the teeth and the alveolar arch, but from the distal contact of second premolar to the pterygopalatine fossa. Professor Sado Sato describes this posterior discrepancy and is much more important than anterior. Usually when we look to a case, a clinical case, we look to anterior part and we think we have crowding, we need to extract, we need to make stripping, but what about the posterior region? The anterior discrepancy is usually the symptom of a problem and often a consequence of posterior discrepancy. The squeezing out effect leads to change in the occlusal plane, and this is an important factor in all the disharmony of craniofacial system. So anterior discrepancy is like the fever, is the symptom, not the cause. In this case, molars have supraeruption because have no space, so making the squeezing out effect. And this creates changes in 3D changes, not sagittal but to transversal, and create a functional local factor for all the clinical cases in malocclusions like class 2, class 3, and MLDD cases. And this is how it works. Without space, we have the squeezing out effect, we have occlusal interferences, and then change the occlusal plane. So this is a very specific local etiopathogenetic factor for class 2, class 3, and MLD cases. What about class 2 in Homo sapiens sapiens? And in this clinical case, you see this patient wants to have a nice smile. And if we look to the smile, oh my God, this case have everything: crowding, open bite, narrow upper and lower arch, gummy smile, everything is here. How can we treat this? But without extraction. And this crowding, anterior crowding, this is the etiopathogenetic factor or posterior crowding. So let's go to the problem list, and we have excessive high anterior facial high. In this case, anterior posterior growth of the maxilla is very poor, constricted upper arch, insufficient ability of forward adaptation of the mandible, of course, obtuse mandibular angle, clockwise growth of the mandible, and gummy smile. And this is the frontal view. So you can see a very narrow arch in upper and lower arch, severe crowding. And in this case, I got to show this case treated not with aligners, with multi-loop, but I will, because I want you to understand these concepts and then apply, and I show the clinical cases with aligners. So here I have a tongue problem. So we need to expand upper and lower arch. And what is recognized here in these photos from young child is that we have a respiratory problem. And respiratory problems, is correlated with all disharmony of the craniofacial system. If we go to the Monti case, we notice here the inclined posterior occlusal plane. So you can see, observe that mandible is positioned in a retrude position of the mandible. So this mandible cannot adapt because we have a very steepness of the occlusal plane. So we have elongation of the maxillary complex, we have an increase of vertical dimension, very inclined occlusal plane, and the mandible is rotated to posterior region. So we need to change the occlusal plane. In Homo sapiens have the tendency to hyperdivergences because of postural changes, of course, we see. But in these cases, with respiratory problems, and when we have this posterior discrepancy, it's not easy that mandible can adapt. And here the mouth breathing and the muscles are very weak, so they cannot try to adapt with this increase of vertical dimension. So here posterior occlusal plane is the etiological factor. So we need to change this, not with anterior extractions of premolars. We need to solve the posterior discrepancy. And to solve the posterior discrepancy here, we need to extract or the wisdom teeth or the sevens. Here, my option was the 7 because I want immediately to change and intrude the posterior occlusal plane. This is a vertical problem. So what can we do here to change occlusal plane? So we try to extrude a little bit. So we want to flat occlusal plane. We extrude a little bit the superior and we verticalize and intrude the inferior. And changing the occlusal plane, then we have adaptation of the mandible and articular compression. In all concepts, we are thinking the mandible cannot do this adaptation. The mandible only can do rotation in anterior part and posterior part. This is old concept because we don't have a screw here. We have a 3D movement of the mandible, and the mandible have rotation, of course, but more movement in translation. Why we don't extract premolars? For 2 reasons. Most important, premolars are a very important retrusive control teeth. And after that, if we extract premolars, we must collapse anterior region. And we need to have a functional space in the front teeth. And why? Because front teeth are sensorial. And if we have a touch in the front teeth, mandible immediately go in a retrusive position. This is my team that works with me in my clinic and we go to the clinical case. Don't focus, please, in the biomechanic, but focus in the concept. And then we apply to aligners. Problem list: bilateral crossbite, occlusal interferences in posterior region, elongation of the molars, and severe open bite with absence anterior guidance. We apply in 9 months with multi-loop and mulligan. Almost the open bite is closed. In 11 months, we have class 1 already in both sides. And you can see here the adaptation from the first image to the fourth image, adaptation of the mandible through class 2 to class 1. Here is the X-ray that is showing that we extract the 7 and bring the wisdom teeth to the occlusion. And in 18 months, we have this result. So we go from here to here without extraction of premolars, without surgical, and notice that is a surgical case, but we can make a lot of changes with occlusion, and we can adapt mandible even in severe cases. Before and after, no doubt, and before and after. And you can see in the after X-ray, very vertical position of the root, very stable occlusion. Here is the wisdom teeth in occlusion, perfect. And incredibly is here the change from a very steep occlusal plane to a flat occlusal plane, and mandible can adapt. The first image, we can have some compression in TMJ, in problems in TMJ, but in the second image, the forces of mastigation or bracing or clenching or function go through the maxillary components and not to TMJ. And the mandible can go and adapt in an anterior position. And this is the face without surgery. And you can see if we have this concept that we can adapt mandible in front. Posterior view of occlusion, no more open bite, and without orientation, we have a 10 years follow-up. So here, what is in cause is not the biomechanics. Here is the concept. Vertical component, posterior discrepancy, control of occlusal plane, control of vertical growth, and adaptation of the mandible. And in X-ray, the longevity of the case. So the first image suggests extraction of the premolars. This is not a good option for the treatment. We need to have a vertical root. We need to uprighting all the lower dentition. We need to change first vertical dimension and after anterior position components. If we go to this clinical case with smilers, with aligners, I would like to show you here something I don't agree and a mistake that I want to focus and say why we cannot do this in basis of this concept that I explain you now. So this treatment plan, we need first expansion. This is a full class 2 and both sides, class 2 maxillary, and we have a retrude position of the mandible. So we need to start with expansion, then vertical component control, then occlusal plane change, mandibular adaptation, and then we obtain the correction of sagittal components. And this is the X-ray, not so much problem in TMJ, but we have a very extrude anterior teeth. Occlusal plane is steep, not so steep like the other case. We need to expand this axis, of course, and this is the initial aligner 1. And we start here with the expansion. And what we design in the virtual treatment plan, we are obtaining in the reality of the clinical case. This is the lower arch. Then aligner 6, we start a little bit with distalization and expansion. Aligner 6, expansion in the lower arch, not so crowding. And in aligner 8, you can see here in the lower image start the distalization of the 7. So what we predict we have obtained in clinical case too, and we start with expansion and at the same time distalization of the upper arch, but is not sufficient to solve the anterior-posterior problem. Align ahead. And if we look before and after, we have more expansion of the arch. We have a better occlusion, not only for the vestibular, but from the posterior view too. But something here I don't like is the anterior teeth. And why I don't like for this? In this case, they think to start with long elastics to immediately start to solve the class 2. I don't agree with this. And why? Why I explained the first concept. If we put the mandible in a front position, we can see in the lower two images that we miss vertical component. So first and before solve the anterior posterior position, we need to solve the vertical component. We need to extrude the upper front teeth and control the anterior teeth with intrusion and then control the anterior position of the mandible. But there is here another mistake for me is the upper front teeth, upper and lower front teeth, because here we have a very extrude. So to start correct anterior posterior, we need to do it intrusion. So first, we need to expand transversal component. At least at the same time we can do it, the distalization of the upper maxillary, but we need to intrude the front teeth before go to anterior posterior component. And why? Because the upper front teeth, anterior and inferior, they are a very sensory organ. And if we go to this research, we see that they are very sensorial. They have tactile fibers between enamel and dentin. And when the lower front teeth contact with the uppers, the mandible immediately go in a retruded position. So we need to change first vertical component and then solve the anterior position. In this case, we solve the vertical position in a very short period of time, and you can see we have here the open bite case, and if we go closer, we only have contact from the second premolar to the other second premolar. And immediately we try with short vertical elastics, not long elastics, extruding the anterior teeth and intruding the posterior teeth. And in a very short period of time, 2 months, we obtain these results. And the change completely of the face. So before and after, vertical component of growth. And if you see the lateral X-ray, the change of occlusal plane and the vertical decrease from 47 to 44.2. My friend George Coro write this article, The Relationship of Maxillary Three-Dimensional Posterior Occlusal Plane and Mandible Spatial Position, and refer to class 2 and class 3. So in class 3, we have a flat occlusal plane, and in class 2, we have a very steep occlusal plane. And we need to change this malocclusion with the control of vertical and occlusal plane. In the first clinical case, I show the multi-loop. Of course, this is a tool that controls very well vertical dimension and occlusal plane and make the verticals of T. But this is a tool. And what is important here is acquire the concept and apply with aligners. It's the same. It's not biomechanics, it's not technique, it's the concept. Another case, but a functional orthodontic treatment, this female cannot bite well and have a lot of headaches. And if we can see the face, we have different eye of the eyes. We have a shift to the left side of the maxillary, upper maxillary, and a shift to the right side of the mandible. And upper and lower arches are very narrow. In the right side, we have a full class 2. In the left side, we have a class 1. And a very severe shift of midline. This is adult case. This is a severe case, surgical perhaps, but we treat without surgery. And if we can observe posture, we have different levels of the shoulders. But if we ask the patient to put the midline, the lower midline correct with the upper midline, we can see in this image that we have different occlusal planes, different vertical dimension. So we need to correct these two occlusal planes, these two vertical dimensions, to mandible can adapt. So if we can realize perhaps is not a class 2 one side and class 1 one side, they are class 2 in both sides, because this is a functional shift of the mandible. My friends talk about this too in MLD case, in the position of the mandible. And he said that the direction of mandibular lateral deviation is consistent with the steepness of the occlusal plane. So where is more steep, the mandible goes to this side. So we need to correct, increase vertical dimension, and then give some torque in the other side to adapt the mandible to the correct position. And what are the objective treatment is solve the crossbite, change mandibular position to a TRP, correct vertical dimension, and treat with different two occlusal planes, correct the class 2 on the right side, and solve the midline shift. And this is before, and in 20 months of treatment, we have the final result. Before and after, before and after, and 8 years of follow-up. And what I want to show more here in this case is the function. Before, a very severe closed mouth cannot open very wide, but after is increasing the height of the mouth. And face, the asymmetry. Before, we have different position of the eyes, and after, they are more equal, like occlusal plane. So, through occlusion, we can change the whole craniomandibular system, because posture are very connected, close connected with occlusion and craniomandibular system. And this is why, because we don't have only 2 articulations, we have 3 articulations. TMJ on the left side, TMJ on the right side, and atlas axis. So all is connected. If we go to this case with aligners, this clinical case have essentially no posterior support. We need anterior control because the front teeth are very steepness, and we need angle of this occlusion. The chief complaint of this patient is pain, a lot of pain in TMJ, in muscles, a lot of pain. Medical history is healthy, but in dental he makes a bruxism, not only in night, but in day bruxism too. He have a very vertical upper incisors, low vertical dimension, and already abrasive condyle mostly in the left side and the right side. So here we don't have, if we go before we go to the intraoral photos, I want to show this. In dental history analysis, we have an occlusion index of 1.9. What this means? This means that he had some problems in chewing, some teeth sensitive, that he had abraded teeth because of the bruxism, headaches, and problems in posture. And in these cases, I go to muscle diagnosis, palpation, and the result was that in the left side, we have pain in pterygoideus medialis, myloideus, and in the left side, masseter, pterygoideum medialis, myloideus, and digastric, retrusive muscles. So this is a case, a clinical case, mostly with the craniomandibular system. Because if we go to the intraoral photos, we don't have so much severe case like the other cases that I show you. It's a little bit narrow, the upper arch, of course, and we have the front is very vertical and is blocking the mandible and going through the position. So, and you can see in the lower arch the abraded teeth. So this is more function, more in craniomandibular system than in a position of occlusion. So, but we need to change occlusion to have harmony in craniomandibular system, harmony and neuromuscular system. And if you can see here before and after, there is not so much changes in teeth, but if we look in the upper arch, we see a lot of changes, mainly in transversal parts, expansion. Why? We need, you have here in this side, we need to have the lines, this principle of lines correct in our dentition because we have a closed heart. We have, like you see in the evolution, with this closed heart, mandible go in the retrusive position. And if we have more compression, more the mandible goes back and more we have problems in TMJ and all neuromuscular system. So the green line is the static line. This line goes through the cuspids and don't have to touch the lower arch. The red line is the active line, is where the lower arch coincides and we have mastigation. And the blue line is the protective line and the occlusion and support. So we need to expand this case because we need to have good functioned lines in upper and in lower arch. This is the upper lines and the lower lines, and they must have coincide the upper with the lower. So in final photos, you can see not so much changes in teeth, but a lot of changes in face. There is in the left side a pain face, and the right side you don't have so much pain face. And if we go to occlusal index, we change immediately from 1.9 to 1 point. Only have some teeth sensitive and some problem in posture. Don't have now pain in joints and don't have now pain in muscles. If we go to condylography, we see that before the movement is wide and shift a little to the right side. And after treatment, they are very stable, the position of the right and left TMJ. So we need to change our mind and our concept. Of course, biomechanics is important. We need to know how to do it, but the concepts behind biomechanics, the biology, are very important because it's the key to solution any cases. Severe cases, surgical cases, functional cases, posture problems, posture and craniomandibular system problems. So we can solve if we have the concept. So the biological bone wears in occlusal medicine, I achieved that we have an incredible human organism. We have a bioplasticity. We can adapt We are not a fixed structure. We are a very high complex structure, but very adaptable. And not only in evolution in past, we are more adaptable now than before. If we go another clinical case and you observe here, we have a not very symmetric face. This is the smile. This is not a severe case. We have a compression in upper and lower arch, crowding in lower, a class 1 in one side, a class 3 in the other side. And this asymmetry we can observe too in the frontal X-ray. So if we put this image and we cut half left and half right, and we combine the two left sides, we have a completely different person. And if we combine the two right sides, we have a completely different person. So this is notorious as the asymmetry in this patient. We start the treatment. What we obtain in the virtual, we obtain in clinical. We are expanding, correcting the arches, most transversal. The crowning in the lower is going to solve, as we see in the virtual. We continue to expand, creating torque, not so much crowning now, and the final results expand, no crowning. Now we go to the implant, but in this case, for me, more important is that the asymmetry of the face. This is before, you can notice not good occlusion, and after, the difference of the smile, before and after. If you go to intraoral photos, not so much different, but if you go to the image, you completely change the facial. So occlusion is the key for all the craniomandibular system. Another case is before and after, and the change of image, before and after, before and after, very crowding, narrow arch, and after, and they are happy. What's happening here is that we change occlusion, we change the self-esteem of these persons and social life. So people may not remember exactly what you did or what you say, but they will always remember how you made them feel. For me, occlusion treatment is a 4D treatment, not only in 3D, but including emotions too. And this is a challenge for us in medicine. So with the clinical practice, function and aesthetic, we change self-esteem, the behavior, and we create wellness, body and mind health. So in summary, for me, occlusion medicine have three very important components: posterior discrepancy, occlusal plane, vertical control. And we, through occlusion, this key, and we have this in our hands, very powerful. We can have emotions, outcomes, complete harmony of craniomandibular system, and correct posture. So the human body is a complex, and we can treat all through occlusion. So for me, occlusion medicine of the 21st century is the human organism, and we have the key that is occlusion. And more than techniques, we talk about concepts and philosophy of treatment. Thank you for your kind attention. Some questions? I think I go very fast. I wait some questions from the audience. I wait a little bit. Okay, a second, I will wait. Okay, how do I programmate the change occlusal plane in the clean check? If there is a class two, sorry, we need to change the occlusal plane to the steep to flat occlusal plane. So we have to extrude the upper teeth and verticalize and a little bit intrude of the lower. We know that in aligners, the extrusion is more difficult than intruder. So we need to see that if the space we need to extrude is enough with aligners or if we have to use screws to help us in these cases. The second question I have here is the same. Okay, so if there is a little change of occlusal plane, we can do it with extrusion with aligners. But if we have a lot of change of this occlusal plane, we need to have screws to help, or even after aligners make some tabletops to compensate the vertical component. Another question? No, the question is if I treat children with aligners. In my practice, 20 years of orthodontic, aligners is a treatment that I do not so much time, but I prefer adult case. I don't treat children. But my colleague from Portugal, Monteiro, explained a very good presentation with the aligners and children. Another question? The question is what aligner brands you use. Okay, I'm using Smilers from Biotech. In 1999, I made my first course in Invisalign. But then, with these old concepts and philosophy of treatment, now I'm working with the Smilers, and I try to apply this concept and this philosophy to these brands and group of orthodontics. It's not only a brand, it's a family, it's a group of orthodontics, and I'm very satisfied with the results. More questions? I don't know if there is more questions. If not, it's okay. I'm waiting for a signal from the other side. If not, thank you very much for your kind attention. It was a pleasure to speak from here, and I have a pity because I like the interaction with the other people on the other side, but with these all circumstances is not possible. Thank you for your time And I hope I share in a good way, my concepts and philosophy of treatment and occlusion. One more question. This is the good question. What Professor Sato thinks about using aligners? Professor Sato don't care about techniques. Professor Sato wants to know about concepts and philosophy of treatment. He don't use aligners, but he likes the results and he likes that we apply any technique with these concepts. And this is medicine, not techniques or biomechanics. I think I answered the last question. It's okay for now? It's difficult. I can't see anyone the other side. No more questions? I don't know if Professor Sato is seeing this webinar, but if he's seeing, I hope he enjoyed the application of all these concepts and philosophy to any technique. So, hello, can I say goodbye? More questions? I'm waiting for an answer by the organization, but I think it's okay. So again, thank you for your time. Thank you for your kind attention. See you. Be safe. Agora como é que eu faço para coisa? Hugo, ajuda-me aqui a desligar. One more question, okay? I'm waiting for the question. What is occlusive medicine? Interesting question. For me, occlusive medicine is, when I talk about this concept, is we are all working not in teeth, not in occlusion or malocclusion. We are working in human body, and I would like to consider that we are all making right or wrong, but making what we call a good medicine to our patients. And for me, occlusal medicine is what we are doing when we apply concepts and philosophy of treatment to occlusion, and through occlusion we can treat asymmetries, pain, posture problems, self-esteem, everything. For me, this is occlusal medicine. Which system are you using? I already said the smilers from biotech. We have one question left from our participants. Can you answer with a written form in this case? I don't know. Can you make more clear the question, please? The last one. Can you make the question, please? Last question. I'm waiting. Organization. Can you program the sequential disocclusion in CleanCheck? I don't have here the software to make this answer in this question, but very soon we go to give a postgraduate course in aligners, and this is one model of this course where we are going to program it in software in CleanCheck step by step to make this occlusion and change the occlusal plane.